Productive Dentist Academy podcast network.
I ask dentists this all the time, and I would say 95% go, well, I'd rather have an inlay or an onlay. I'd rather have that type material. That's what I have in my own now. Why? Because I didn't really want the composite resins. I'd rather have something that had a great chance of lasting the rest of my life. So that philosophy went on with my patients. Why do we not offer those to patients?
Welcome to Investment Grade Practices Podcast, where we believe private practice dentists deserve to get the lifestyle today while building an asset for tomorrow. Join your host, Victoria Peterson, to design the practice of your dreams and secure your financial independence. Let's get started.
Welcome back to Investment Grade Practice. I'm here again with my partner, Dr. Bruce B. Baird, continuing our series from the chair side to the boardroom. We both have done that. We've both been clinically chair side and taught a lot of clinicians and then taught a lot in practice management. And in this episode, from chair side to boardroom, we're connecting the value of clinical systems to practice value. And Bruce, in this episode, I want to talk about diagnostic drift and how that just destroys the value. And just to set the stage, a lot of times when we first talk to doctors, they have a philosophy or they know what they want, but it's living in their head. What do you think happens to a practice when it's all just in the doctor's head and isn't communicated to the team?
Well, I'm kind of an expert at that, actually, because for 15 years in practice, probably 18 years in practice, everything was in my head. I just expected my team to know what I was thinking. And truth is, I didn't spend much time training. I didn't spend much time. I had expectations of excellence without teaching excellence, without working with my team to teach them. The philosophy of care is one thing, but having us all on the same page as far as what do we do when we're doing a class 2, class 2, 3 surface, 4 surface. What do we do when we're doing endo? What do we do? In other words, having everybody on not only chair side, but the front office understanding everything. And that's really where clinical calibration, you're going to lose so much value when your team, every day your expectations are different. And so what I found was, it's like, if I sit down with a team member and I just become the continuous instructor and asking questions, and my day, it's really hard to do. We talked about scheduling before, but really hard to do when you're running behind. So it's which comes first, the chicken or the egg. And in my practice, I don't know which came first. It was the scheduling philosophy that came up first, as well as my philosophy of care. But it allowed me to teach my team, this is what I expect when I see a temporary crown. I want it to be polished. I want it to look almost like the real crown. And, Summer can do, I've got a temp on 27, and it looks just like the permanent. And because she did it. And I'm like, how did you learn to do that? Well, not only did she get thousands of reps, but I taught her exactly what I wanted. Then I never had to teach her again. Now if I saw something, that's what we always say, a training opportunity. That's where I would say, okay, Summer, you notice that little jagged edge on that margin? Oh, we need to fill that in, because that's going to change how the tissues come up to the tooth. And then when we try to seat the permanent, it's going to be harder. And, all of those things. Same philosophy when we start talking about technology. I asked doctors, what type of restoration would you like to have in your mouth? And diagnostically, it's interesting. People who don't extract wisdom teeth rarely recommend extraction of wisdom teeth.
Is that right?
Yeah, it's pretty crazy, but oh no, those will be fine. Yeah, when you get a little.
Are you saying your skill set kind of creates the lens that you see the world?
100%.
Okay, so if I don't do CIRAC restorations, what's the difference between having a milling unit in my office and sending everything out to the lab? What would shift in my diagnosis?
Well,
I mean, we always look at that as like a cost thing, right? But it's not just cost.
I would ask the doctor this simple question is, if you had a choice of materials in your mouth and you were having a filling done, four surface composite, and that's what you were recommending. I mean, is that what you would recommend? What type material would you like to have? What type composite? Would you rather have something that was pre-made and put into that thermal cycles just like the tooth, that's bonded in place, that has a chance of lasting the rest of your life? Or would you like a composite resin that would give you 8 to 10 years? You know, I ask dentists this all the time, and I would say 95% go, well, I'd rather have an inlay or an onlay. I'd rather have that type material. That's what I have in my own mouth. Why? Because I didn't really want the composite resins. I'd rather have something that had a great chance of lasting the rest of my life. So that philosophy went on with my patients. Why do we not offer those to patients? Well, you ask the one who wants to send it to the lab, or the one who wants to do it in-house. If you want to do inlays and onlays in-house, easy. I mean, it's so much easier for me to do a 3-surface indirect restoration than it is for me to do a 3-surface composite. I mean, I prep, I walk away, it's tried in, it fits perfect, and we bond it. So it's simpler for me and it's better for me. But what about the doc who doesn't have technology? What they're going to do is, it becomes, first of all, doing an inlay or an onlay temporary is a nightmare. Very old. They come out, they break, they'll end up fracturing the tooth because it wasn't done properly. Bottom line is, that's when the doc becomes either a crown or a filling guy. There is no such thing as inlays and onlays. I either do crowns or fillings. Well, when does it become a crown, doc? Well, I don't know. It's just how I feel that day. I look at it and I go, ooh, this is a big one. I think I'll do a composite to get it. I don't think you could afford a crown. In other words, you start worrying about what patients can afford and what they can't afford, when in fact, they're coming to you to get advice on what they need and what would be best. I'm always going to tell them the best option in my own mind. Now, if I had never done any training with CEREC, if I'd never done anything, and all I'd ever done and at CEREC, there's so many other milling machines now. We say CEREC, but there's milling, there's fast mill, there's all these different things. AI is making it, if you think, oh, well, those aren't as good as the restorations if I send it to my lab. Well, I hate to tell you guys this, but your lab is using AI milling. So you're nuts if you think that. So if you have your own milling machine, which, oh my gosh, that's a lot of cost. You know what? When you start looking at it, it's very cost effective.
Yeah, you get your ROI on it in the first year.
I mean, people say, yeah, but you have to buy $100,000 machine. Well, you could, but I pay for that $100,000 machine weekly. I mean, it's like, I'm going to pay for this. Why? Because I was working 2 days a week for the last 14 years in practice, but I was doing 100 units a month on 2 days a week, 100 units of inlays and onlays and crowns. How? Because that's what I recommended to the patients. Now, would I ever have some people say, I just really would rather have a filling? Okay. I'm cool with that.
Let's pause right there, because you're bringing up two things that are lessons, or actually courses in our Clinical Calibration Institute campus. One, you did a beautiful course, and thank you for doing this. It only took me 20 years to get you to like throw your hat. You have some of the biggest clinical chops I've ever seen. You're a diplomat or a fellow in almost every organization, but over time, you're like, no, I want to help people in their communication skills and their business skills. And I really respect that. And until now, there was such argument over CR and CO and all that. And I respect that you didn't want to get into that either. But this course that you did on diagnostic distinction and differential diagnosis between class 1, 2, 3, 4, 5, really looking at distal and occlusal and those lingual cusp, really looking at the depth of the decay and when does it get into the pulp and all that. I'm so excited about that one course, because in like 15 minutes, you clarified so much. So that's a new course that we've developed that goes beyond traditional Productive Dentist Academy training. And then the second one is, I'll give this up to Dr. Joe Valenzi and his office manager, Lisa Rogers. If you remember them down in Daytona area years ago, she was a school teacher. And Dr. Joe was a former instructor at Yale Dental School. So he's a teacher. And he said, Victoria, why can't I get my assistants to actually do it? I've taught them and I've shown them and I've trained them, but they still won't do a great impression or attempt. And I said, well, you need to stop teaching and let them start doing. So Lisa came up with this system called MAD Skills, Mastering Assistant Duties, and created a leaderboard of here are the diagnostic things that an assistant has to master. On a scale of 1 to 10, have you mastered it? Here are the restorative, basic restorative, advanced restorative, surgical, ortho. So the assistants could build their skills. And she put it up like a teacher, right, on the bulletin board and made a poster out of it and decorated it. And everybody in the office got to cheer the assistants on because everybody's name was there. And the goal was to get each assistant to an 8 or above on that particular thing. So if it was, the diagnostics, we're going to cheer Summer and Gay and Cammie and everybody on until everybody gets to an 8. And it was just like you said with Summer, you're like, this is what a great temporary looks like, feels like, seats like, very detailed. And then when you know that they're at an 8, you can delegate and live with maybe the 20% course correction. So you pointed out a couple of really great courses that even if you've been in PDA for a while, we've got on our new campus. That's pretty exciting. So these are some tools that we're building to help prevent that diagnostic drift because you get busy and you get tired and you forget. So how do you, beyond that, I know you've mentored a lot of young docs. How do you get them up to speed with expanding? I heard you talk a lot about expand your vision, right? Like go beyond just the emergency, one tooth. How do you help young doctors to expand their confidence and expand their vision?
Well, I do think, it goes back to the original systems that you put in play in your practice. Now, what about all those docs that don't have a system in play in their practice? Well, it's really hard when you're stressed and you're running behind and doing all those things to do all the things that we talk about. So what I try to do is I work with these young docs to give them, and most of the guys that I end up working with are people who do want to do comprehensive dentistry. I don't really think I lose interest when somebody says, no, I really enjoy what I do. I love doing one crown. I don't want to do full mouth rehab. Fine. I hope your life is good, but I'm not going to be able to help you because that's not my philosophy of care. So, but doctors who have a philosophy, they want to help their patients at the highest level. Let's get your scheduling properly. Let's get all those things right to reduce stress. Then guess what? You may be working less, making more, but you're also going to have a goal of, when I ask the docs, what is it you would love to do? What is it you love to do, or what would you love to do? And if you love doing a certain thing, then that's how we target their marketing. If it says, I would love to do all on X, well, then good. Here are the courses that I would take if I were you, so that you will now expand your knowledge, expand your treatment options. So
I want to make sure I'm sorry to interrupt you. I want to make sure we just don't skip over this step.
Yeah.
Because sometimes people hear comprehensive care and they automatically default to, oh, he means I have to do all on X treatment, or he means I need to do, a certain type of dentistry. What if I don't place implants? Am I not a comprehensive? So back up to the diagnostic piece that you calibrate to, go back to the risk factors and what does comprehensive care really mean?
Yeah, a lot of us, one of the things when I heard John Coyce talking about risk factors some 20 some odd years ago, it was an epiphany for me, because I realized that a lot of the dentistry that was failing that I had done wasn't my fault. It was because of the habits and the inherent risks associated with that particular patient. And so I go through the risk factors with the patient. That builds a treatment plan. It's not good enough for me to do a filling that I think is, I'm going to give you this. I don't think it's okay for me to do 5 buildups, not crowns yet, just 5 buildups without talking about nutritional counseling with my patient, without talking to him about all the shit they're eating, all the sugars and all this stuff. You're drinking Dr. Pepper all day long. Once they understand that, then they can become my partner, and maybe my restorations will last. Maybe they'll continue to do the things that they're supposed to do. Maybe they won't. But it's not my job anymore. I've given them, I've gone over their risk factors. I've gone over what they're doing to increase their risk and what we need to change. It's not good enough for me to just tell a patient, yes, I can do the filling. And we've talked about that. If they say, can you do a filling on this tooth? Yeah, I can, but wouldn't you want to know how I would do it if it was going to last the rest of your life? Unless you like coming in every 6 years or 5 years. No, I want it to last the rest of my life. Well, if you want it to last the rest of your life, you're going to have to wear the occlusal guard. You're going to have to quit drinking Dr. Pepper, or at least understand what Dr. Pepper is doing to you, or Mountain Dew, or Big Red, or whatever it is. And once you understand that, I've done what I can do, and it ain't my problem anymore. It's now your. And, so my stress levels go down drastically when things used to fail in the practice, which it does. Dentistry fails when people, it just fails. That's the way it is. But I was stressed. It caused me stress every time something that I felt like I had done a great job on ends up failing. But I never did look at their risk factors. I never looked at the sugar. I never looked at them not wearing an occlusal guard. I never looked at any of that.
Doctor, are you tired of repeating yourself with your team over and over again, and yet you still see treatment walk out the door? If so, you're not alone. The Clinical Calibration Institute, powered by Productive Dentist Academy, is an all-new online platform that unites your team around your philosophy of care, so patients can say yes with confidence and you grow with purpose, including online curriculum with world-class faculty, monthly live mastermind sessions for each department within your practice, and an online private community. This is your home to grow. Head over to clinicalcalibration.com today to join every member of your team for one very low monthly membership fee. That's clinicalcalibration.com.
So now you can get diagnostic drift big time, if you're not going into the causative agents, why things are happening. And once the patient understands, your stress level drops drastically. Patients will come in and say, I thought, like my old implant patients, I thought this was going to last the rest of my life. And I told him, Joe, I didn't know you were going to live this long, and he didn't follow any of my advice. I didn't see him for 20 years and he shows up like it was supposed to be magically still in there. But those are all things that are important.
I want to put a pin on this really important piece. Most people, when they hear diagnosis, our brain automatically defaults to, I've got a patient in my chair, I'm looking at them, you got a hole in your tooth, let's fix it. What I just heard you say is that diagnosis is more of a continuum. It's not just one moment in time. It's this really being this healthcare detective of, let me look at your medical history, your dental history, your lifestyle habits. I want to figure out how you got here. Then I want to know what here is.
Yeah.
And I want to know how to prevent this or reverse it in the future. So diagnosis is really discovering the risk factors, connecting it, and then preventing it. Would you say that's accurate?
It is. And the patient, you have to do a good enough job so the patient has understanding. You have to have the time to be able, and time, I go through all 4 risk factors with new patients in probably 8 minutes, 6 minutes. And they understand. They go, oh, I didn't know that. Oh, well, good grief. And then what do they say? Why has no one else ever done an exam? This is the best exam I've ever had. When in fact, I haven't even really told them what they need with their teeth. I told them why all the stuff. And I would say, Victoria, I know it's pretty frustrating coming in and always having dentistry that needs to be done. Would you like to change that? I mean, I think we can change that. Well, yes. Okay, maybe that motivates that patient. The periodontal patient that's had apically repositioned flaps and bone reduction and pain, those people, they get religion. Well, I'd prefer to get them, without doing all that.
Right.
But the patients have to have an understanding of why they're having the problem. Then you're not a drill and fill. You're an advisor. You're a consultant on their dental health. And when you change your whole philosophy to say, you know, Victoria, there's a lot of options. There's multiple things we could do, but let me tell you, with your bite and with your periodontal risk, and in my own mouth, this is what I would do. Well, if you come at it from that perspective, the patient can't really say anything about that. I mean, if you've built trust and relationship early in the appointment with a new patient, then all of a sudden they believe you and they listen to you. And now you're doing more comprehensive dentistry. And I want to say, if you're not doing inlays and onlays, that's fine. You might be the best dentist in the country at doing four-surface posterior composites. You may love doing those and doing them yourself, and all of that. My only statement about that is that's fine. And these restorations can last a lifetime as well. It's just, what are we starting with? One, we're starting with maybe a ceramic material that has been engineered to thermal cycle, and then we got a composite that we squirt in, and we hope that lasts. But
Well, do you think that there's a difference based on, like, this is a low risk patient that doesn't have a lot of acid? It's their first cavity ever and they're 40 years old. Like, that's a different patient than you're in your late 30s or 40s and this is your 15th and they're breaking down and the Dr. Pepper and the acid. Like, so I think that's what we're excited about really diving into deeply. Every I think there were 6 disciplines to complete a comprehensive exam. I don't even know if I can name them all, but you got to look at caries, perio, function, airway, aesthetics, and maybe endo implant, periodontitis, right?
and psycho risk.
Well, and psycho risk, yeah. But those 6 clinical disciplines, if you were educated, pre-2000s, some of the stuff wasn't even in our nomenclature, like general dentist screening for airway risk has just become mainstream in the last 10 years. Like, you and I have been aware of it and teaching it for 20, but it's just now becoming mainstream. And the American Dental Association and the insurance codes now include airway screening in that comprehensive exam. And I bet you more than 1 or 2 people listening to this podcast just got their hair raised and went, well, what do you mean? I've got to screen for sleep apnea. I don't screen for sleep apnea, but it's part of the risk. How do you get people healthy if they can't breathe?
Yeah. I mean, it's not only breathing, it's the acid that comes in their mouth when their epiglottis snaps shut, when they're snoring and they have that big gulp. And all of a sudden you have acidity in the mouth that affects your dentistry. Apnics also tend to grind the crap out of their teeth. How do I know? Because I am one. But so when you see somebody that has severe wear, as well as, erosion, as well as a 17.5-inch neck for a male or a 16.5-inch neck for a female, and they snore, they got a 95% chance of having sleep apnea. I don't care what you do, what kind of dentistry you do. And you don't even have to treat it. You can send them to a sleep lab and say, go, I don't want to treat sleep. Fine, but at least diagnosing it and getting them treated is going to help your long-term results. And that's what I'm interested in. I hate redoing stuff.
I know. This is a curveball question. How do you tell the difference in erosion when it's apnea versus maybe eating disorders or a medical condition with GERD or I don't think there is a lot of toothbrush erosion. I think that's a myth, but how do you tell, like, what's causing that erosion?
Basically, location. When you see the location of the erosion, a lot of times if you're seeing the linguals of the uppers of the upper anterior teeth. That could be bulimia. You're starting to see erosion in the posterior areas. That might be apnea. So it's a differential diagnosis. You're looking at all of this and you're saying, okay, what is causing this? Because I want to get to the bottom of it. And by the way, Victoria, what medications are you on? Okay, I notice you have a dry mouth. Well, okay, maybe that's the problem. Maybe now we can't get you off the medications, but we certainly can get you on, rinses that can help and can neutralize the acid in your mouth. So those are all differential diagnoses where you're just like if you were somebody came in with a bellyache, if you were a physician, you'd have to figure out, okay, what's causing it. You look at the different things. I'm pretty astute at asking questions, and so if you ask enough questions, you're going to get, and especially if you're in good relationship with the patient and you say, I know this might sound crazy, but do you snore at night? Oh, well, my wife says I do. Oh, okay.
She might be right.
Well, she may be, or the
You
wife.
know, I love how this is full circle because in our previous episode, we talked about scheduling and having the time to sit and talk to the patient. And, you've in this episode given us so many reasons why you want to sit down and create that rapport and gain their trust and then ask some of these really sensitive questions. It takes a lot to slow down and be there, be present, be empathetic, because don't you think that patients feel like, if I go to a physician, then it's like my body betrayed me. Something happened. I was talking to my dad the other day and he goes, "Oh, your Uncle Gary, the diabetes done come and jump on him." That's a very Southern thing, right?
Yep.
Nothing that Gary did throughout his life caused diabetes. That diabetes just jumped on him. But when you go to the dentist, it's this felt sense of it's my fault. But it's not always, right? It's the bacteria, it's the acid, it's the genetics, it's so many things.
Yeah, give them a solution. I know that, when you're going into hygiene, you have 3 minutes or 4 minutes to tell somebody about their risk factors and everything else, you're probably going to miss a few things. You're not going to build a relationship with the patient. It is going to determine what type of dental practice you have. And so my preference, because I want to have time to get to know my patients. And when you get to know your patients, guess what? They don't miss their appointments. They show up. They pay, because they want what it is you're offering. So Clinical Calibration Institute is something that's going to bring all of this together in bite-sized chunks that you can get in your head. And it's not about just training you as the doc. It's also training your front desk, your chair side, your associates, everyone in the office calibrated to a philosophy of care and to specific modes of treatment that you want to do so that everyone understands this is what we do in our practice. That doesn't mean what we do in our practice in 2025 is the same as it's going to be in 2026, because there's going to be new things that come up. There's going to be new materials. There's going to be new bonding. There's going to be new all of this. So just having the time to be able to stay up on what's the latest and greatest and producing at the highest level. I want to produce at the highest level, and I want to work as much as I want to work.
Well, let's end this episode right there with you are a huge proponent of hygienist. And what is your expectation with your hygienist co-diagnosing? I'm going to put the co in there because we're all afraid to diagnose, but everybody on your team should be able to understand, right? So what is your expectation of your hygienist when you walk in for the exam, for the hygiene annuity? I mean, we teach a 1, 3, 5-minute exam. How is that accomplished? What is the hygienist doing to set the doctor up for success?
Well, I mean, there's a couple different angles to that question. One is, what do I want the hygienist to do? And I want them to become oral healthcare experts, which they are. I want them to look at a patient, just like Michelle working for me for years and the other hygienist. I want them to see the same things I see. In other words, when I see it and they see it, we're on the same page. Whereas as opposed to me going, oh yeah, your gums will be fine, and yeah, it'll be good later, just brush better, that kind of stuff. We have the oral systemic connection is amazing. We're finding out all kinds of things. So I want my hygienists to go to courses on that. I want them to read about that. I want them to become the leading expert on the oral systemic connection in the practice. Now, to me, when they do that, that gives a different perception to the patient because now they're a healthcare provider. They are truly changing how you live. And that is critical. The flip side of that is, and hygienists now, there are hygienists making 120 grand a year, but I'm pretty sure they're producing more than 120 grand a year, by doing additional services, additional treatment that is well documented, well researched, doing laser pocket disinfection, doing all the things that they do. But from a hygiene standpoint, when I walk in, it becomes very easy. If we're doing a comprehensive exam and a patient needs 10 restorations, but they only did 3, is it my problem? No, I told them all they needed. Now they're floating in my hygiene annuity. They're coming in every 4 months. Maybe they're coming in every 6. Maybe they're coming in every 3. But at some point in time, my hygienist, I just want them to be aware of what the recommendations I had before, pointing out things when I come in and talk. Dr. Baird, I was worried about tooth number 19. We scheduled it for an onlay, but I'm afraid it may need a crown. Okay, great. I look in, I go, I agree. Bob, it's time. And that's my 2 words that I use. It's time. And I just look at him and nod. I said, let's put this on the front burner as soon as possible because I just don't want this to turn into a root canal or lose the tooth. And so I walk out of the room. I couldn't do that if I didn't know the patient, if I hadn't spent time to get to know the patient, if I sent them into my hygiene annuity and they had never met me more than 3 minutes in a hygiene exam, my treatment plan would be $2,500, and that might be a crown and a filling and something else. It wouldn't be a comprehensive evaluation of their risk factors as well as what dentistry they need to have done. It just wouldn't be. And so in that statement, I would not be taking comprehensive care of my patient. I would just be doing whatever the patient asked me to do.
Order to cook.
Yeah, that's it. What do you want? And I chose in 1991, I could have signed up for every plan that was out there. I never have, but, and then just had all these patients come in, hire a bunch of associates and just say, fill and drill and do all that. And I'm going to go play golf. But I didn't want to do that. I wanted to take comprehensive care of my patients, and my patients respect me for that. And they refer patients because you got to go see Dr. B, and they do the same thing with Dr. Busquet. You've got to go see them. Why? Because they think different. Yeah. And you want to have a different practice. If you want to lower your stress, double your productivity, then you need to sign up for CCI. That's about all I can tell you.
Well, I'm glad you highlighted hygiene because Michelle Hudson is on faculty for us. And in fact, a core pieces of content are taught in by Michelle and by Summer and by myself and others so that your team understands this. It really is all about helping the owner doctors and the dentists get really clear on their philosophy and their diagnostics, and then documenting it. And we provide the training. You just have to provide the time to take the materials, walk through it, and discuss it with your team. That's really what we saw missing. And you and I do a lot of work through investment grade practice. I do a lot of work with seller readiness and this and that. And when I'm evaluating practices to go to market, I'm like, you just missed out on about, $10 million over the last 10 years. Your stress could have been lower. And not that it's about the money. For both of us, it comes down to you have patients that need this. that you just weren't organized, and now the next person who buys your practice is going to get the benefit of that. So it's
You would gold mine. That's true.
yeah,
You'd gold.
gold mine for somebody, but it won't be the gold mine for you. So all of this leads to two things. One, amazing care and helping great dentists, kind of create systems that are not only productive but profitable and building value along the way. That way, when just like you did successfully, when you're ready to put down the handpiece and step away, the value of the practice doesn't drop; it continues. And
Yeah.
especially
Improving.
anybody who's thinking about partnering with a DSO, it's critical. Like if you sell your practice and it drops, there are penalties. So the world kind of gets real when you get to those end stages.
Yeah.
Bruce, thank you so much for highlighting your philosophy of diagnostics and how diagnostic drift, happens so easily if we're not paying attention to it, and just showing us how it erodes patient care and it erodes the value of your business.
Absolutely.
Thank you for tuning in to this episode of Investment Grade Practices Podcast. If you find value in this episode, help us spread the word by passing it along to a dental friend, subscribe, and give us a like on iTunes or Spotify. Learn more about building your investment grade practice at productivedentist.com today.